Bismillahirrahmanirrahim. Welcome to ERA. I am Dr. Muhammad Talat, Assistant Professor of Radiology at University. Today, inshallah, we will talk about the second part, MRI of the prostate. Today, our objectives, we will discuss the detailed anatomy of the prostate and segmentation model of the prostate. I hope you enjoyed our first part, MRI protocol of the prostate. If you didn't watch this video, it is available in the YouTube channel. Also, I would like to announce that I uploaded many short courses before. You can watch emergency brain course, MRI of epilepsy, MR topography. Also, I uploaded many teaching Viva sessions, including many parts of the body. Let's start our topic today. Before starting our topic, I would like to emphasize that I have many sources. I reviewed all of these sources in the first part, in the last vignette. But today I add to these sources, this is an important article regarding the prostate imaging reporting and data system version, because we are using now the last version of the Pi-RADS version 2.1. Okay. Let's review first some important tips regarding the anatomy. This is the vas difference, and this is the duct of the vas difference, and this is the seminal vesicle, and this is the duct of the seminal vesicles. Both of these ducts are united together to form the ejaculatory duct. So this is the ejaculatory duct. Ejaculatory ducts is formed as a union of the duct of the vas difference and the duct of the seminal vesicle. Here in this plane, this is the posterior aspect of the prostate. We have here, this is the tridone of the urinary bladder, and this is the vas difference. This is the seminal vesicle, and here you can see this is the ureter left side and the ureter of the right side. In the sagittal plane, we are dividing the prostate into three main parts. This is the basal level of the prostate, and this is the mid level of the prostate, and this is the apical level of the prostate. Also, in the sagittal plane, you should identify the prostatic urethra. This is the prostatic urethra, and the prostatic urethra is angulated at this point. It's called perimontanum, and this is the site of the ejaculatory duct. And we have here, this is the central zone of the prostate, and this is the transitional zone of the prostate, and this is the peripheral zone of the prostate. So this is the peripheral zone, this is the central zone, and this is the transition zone. The transition zone is located anterior to the urethra. The central zone is superior to the urethra, and the peripheral zone is located posterior to the urethra at the midline. Also, we have here this dark band called fibromuscular stroma, anterior fibromuscular stroma. I would like also to highlight that the central zone, this is the central zone. Central zone is located only at the basal level of the prostate. It is not present at the mid level or apical level of the prostate. On the other hand, the transition zone is present at the basal level, mid level, and to a less extent, the apical level. So the main bulk in the basal level, in the mid level, and the smaller part of the transition zone is present at the apical level. The anterior fibromuscular stroma is present at the three level, at the basal level, the mid level, and the apical level. The peripheral zone is present also at the three levels, the basal level, the mid level, and the apical level. The main bulk of the peripheral zone is present at the mid level and the apical level. And the smaller part of the peripheral zone is present at the basal level. So it is the reverse of the transition zone. The transition zone, the main bulk at the base and middle level, while the main bulk of the peripheral zone at the mid level and the apical level. Also, we have here, this is the peripheral zone at the parasagittal location. It looks like G shape in configuration or hook shape in its configuration. Let's review some important remarks in the sagittal plane. This is the urethus, and this is the urinary bladder, and this is the seminal vesicles. Also, we have here pre-prostatic space of rectus. This one is very important. It is present behind the symphysis pubis. This is the symphysis pubis. Also, we have here, this is the root of the penis, and we have the rectum and the anal canal. As we discussed before, that we have basal level of the prostate, mid level, and apical level. And this is the axial plane of the prostate. As we said before, that we have, this is the central zone of the prostate. It's present only at the basal level. It is not present at the mid or apical level. And we are dividing the central zone into CZ on the right side and CZ on the left side. Regarding the transition zone, we are dividing the transition zone on the right side, TZ anterior, TZ posterior. So we have TZA, TZB, TZA, TZB, TZA, TZB, TZA, TZB, TZA, TZB. As you see, the transition zone at the apical level is much smaller in relation to the other zonal anatomy of the prostate. Regarding the peripheral zone, we are dividing the peripheral zone into PZA, PZ anterior, and we are dividing the rest of the prostate into BZ posterior, and the BZ posterior is divided into BZ posterolateral and BZ posteromedial. So we have BZ anterior, and the BZ posterior is divided into BZ posterolateral and BZ posteromedial. So this is the two parts of the BZ posterior. Some authors describe this part as BZB, BZB, BZM, and BZA. Really, I prefer this classification. So we have here BZM, BZB, BZA to simplify our segmental model. So we have here in the mid-level, we have BZA, BZ anterior, BZB, that's related to the posterolateral, and we have here BZ medial or BZ posteromedial or BZ mesial. So we have here 3 segments on the left side. Also, we have 3 segments on the right side. We have also here BZA, BZB, BZM, BZM, BZB, BZA. Regarding the fibromuscular stroma, we are dividing the fibromuscular stroma into 2 divisions, one on the right and one on the left. Anterior fibromuscular stroma on the left side, anterior fibromuscular stroma on the left side. Some authors describe this one as AS, anterior fibromuscular stroma. We can call it AS on the left side and AS on the right side, as you like. You can describe this one as AFS on the right side, AFS on the left side. And we have also here the right side and the left side, the right side and the left side. So in total, our segmentation model of the prostate regarding the Pi-RADS version 2.1, we have regarding the transitional zone, we have 4 segments at the basal, 4 segments at the mid-level, and 4 segments at the apical level. So we have in total 12 segments. Regarding the central zone, we have only 2 segments at the basal level, right side and left side. Regarding the peripheral zone, we have 6 segments at the basal level and 6 segments at the mid-level and 6 segments at the apical level. So we have in total 18 segments. We have also the anterior fibromuscular stroma, and this is 2 segments at the basal, 2 segments at the mid, and 2 segments at the apical level. So we have in total 6 segments. If we start to complete all of these segments, we will find that we have 38 segments for the prostate at the center between the transitional zone here and here, and the prostatic urethra is surrounded by periurethral tissue related to the transitional zone. So as we said before, that we have 38 segments for the prostate. We will add 2 segments for the seminal vesicle, one on the right side and one on the left side, and we will add also 1 segment for the membranous urethra. So in total, we have 41 segments. And this is the most updated segmentation form for the prostate. We are using 41 segments in the Pi-RADS version 2.1. So let's apply this zonal anatomy of the prostate on the axial T2 and sagittal T2 of the prostate. Before applying this one, I would like to emphasize that we have 2 different planes for the axial T2 with image. We have this plane, and this is the 2 axial T2 of the pelvis, and this one more likely parallel to the penis, to the base of the penis, and also it is perpendicular to the body axis of the patient. And we have also another axial T2 with image that, as we discussed before in the last vignette, that we have here. This is the longitudinal axis of the prostate, and we are using this plane perpendicular to this axis. So this is another plane of the axial T2. According to your institute, you can use this one or the previous one. So let's review our anatomy now. We are using here the axial T2 of the pelvis, not the axial T2 oblique of the prostate. So we have here the central zone. We started by central zone of the prostate. Here, this is the central zone of the prostate. And as we said before, we have CZ on the right side and CZ on the left side. If we go more down here, the central zone is finished, almost finished. So we have here, this is the transition zone on the left side, and this is the transition zone on the right side. We have TZA, TZB, TZA, TZB, and we have also, this is the peripheral zone. So we have here BZA, BZB, BZM. Also we have BZA, BZB, BZM. And also we have here, this is the site of the fibromuscular stroma on the right side and on the left side. So if we are going to take the axial T2 oblique of the prostate, it will be in this plane. And if you take the axial T2 of the prostate, axial T2 oblique of the prostate, you will find in the axial image the central zone, the transition zone, and at the same time peripheral zone, as we discussed before in my diagram. But if you will take this axial T2 in this plane, axial T2 parallel to the base of the penis, or axial T2 perpendicular to the body axis of the patient, you will isolate the central zone away from the transition zone, as you see here. This is the central zone at this area, and in the next slide, you will find only the transition zone and the peripheral zone. If we go more at the mid-level of the prostate, you will not find the central zone at all. So we have here, this is the transition zone, and this is the peripheral zone. And the peripheral zone can be divided BZA, BZL, BZM, TZA, TZB, and this is the anterior fibromuscular stroma. Benign prostatic hyperplasia, we have hypertrophy of the transition zone and the central zone of the prostate. And we will find mix between stromal hyperplasia and glandular hyperplasia. If we find stromal hyperplasia or stromal proliferation, it will be characterized by gray nodules in the T2 terms. While in glandular hyperplasia, we will find bright nodules. As you can see here, this is a bright nodule rich in mucin. So it displays high signal intensity in the T2 terms. So stromal hyperplasia characterized by gray nodules, while glandular hyperplasia or proliferation, it is characterized by bright nodules. Also, I would like to see or to review the apical level of the prostate. Let's review the apical level of the prostate. We have here the transitional zone, and also we have the peripheral zone, and we have also here, this is the fibromuscular zone. If we go more down, we will find this is the membranous urethra, and it is surrounded by dense muscular layer, external urethral sphincter, and we have here the puborectalis muscle at this area. So if we start to review, or if we start to report the prostate, we should localize for the zonal anatomy of the prostate from the basal level to the apical level. Also, we should search for any perianal fistulas, any perianal collections. If we want to localize this lesion, it is located at the PZA. So we have here the mid-level on the right side. So we can say right, mid. PZA means anterior peripheral zone. So we have the right side, mid-level, anterior peripheral zone. Anterior peripheral zone means PZA. This is the correct or precise location of the station. I would like also to highlight that this anterior fibromuscular stroma should be smooth in outline and symmetrical on both sides. Normally, it displays dark signal intensity in T2 attempts, and this dark signal intensity, as you can determine or expect, that the neoplastic lesion most probably displaying low signal intensity. So how can we differentiate low signal intensity lesion within the dark signal intensity of the fibromuscular stroma? This is the rule of the diffusion with Emerson and the dynamic contrast study. We will discuss this one in the next vignette, inshallah. We have also the peripheral zone. Normally, it displays bright signal intensity in the T2 attempts. So once we have any dark signal lesion, it will be easy to be demonstrated against the background of the bright signal intensity in the T2 attempts. I would like also to emphasize that in benign prostatic hyperplasia, the predominant component is the transitional zone and central zone, and together these zones are called central gland. So if I say central gland of the prostate, central gland means transitional zone and central zone. So it is different. Central gland, it's different from central zone. Central gland means I combined the transition zone and the central zone together. We have also some important tips. We have, this is the anatomical capsule of the prostate. And this is called the surgical capsule of the prostate. So the anatomical capsule is surrounding the prostate, and it's very important in the staging of the prostatic cancer. Once we have any focal lesion at this area, you should comment on the anatomical capsule of the prostate. On the other hand, if we have a lesion in the transitional zone and you are in doubt, is this one is malignant or not? If this lesion appears as smear-like or charcoal-like and it's crossing the surgical capsule, crossing the surgical capsule is one of the features that can suggest the malignant behavior of this lesion. So surgical capsule is very important, and the anatomical capsule is also very important. In elderly, you can find marked hypertrophy of the transition zone, and sometimes, in many cases, the hypertrophy becomes more predominant, encroaching upon the peripheral zone, and sometimes the peripheral zone becomes thinned out or stretched behind the transition zone. Also, we have here at the midline, this is called the median raphe of the prostate. Sometimes it appears more prominent, as you can see here in this image. Also, sometimes it is characterized by nodular thickening, and this is considered normal variant. But take care, if you are still in doubt, is it normal or not, you should review the diffusion with image and the dynamic contrast study. We have also at the peripheral zone some radially arrayed bands of dark signal intensity as the T2 with image. This is considered normal. We have also some important landmarks. We have here, this is the post-seminal vesicles. The seminal vesicles are larger in younger age group, and by progression of the age or in the elderly, you will find the seminal vesicles slightly atrophied and the secretory materials will dry out. This is the secretory material displaying bright T2 signal. This is seminal vesicle as well. We have also some anatomical landmarks. This is a urinary bladder, and this is the pons ureters. Let's see the pons ureters. As you see here, this is one ureter, and this is another ureter. We have another anatomical structure here. This is the vas deferens. This is the vas deferens. And the vas deferens going to join the duct of the seminal vesicle to form the ejaculatory ducts. And this is the central zone. We have also some important anatomical structures. We have posteriorly the rectum, and this is the mesorectal fascia, and this is the pararectal space. Should be clear. We have also retroprostatic fascia at this point, and the rectoprostatic fascia united together with the mesorectal fascia at this point. So you will find this fascia appears thickened at the midline because of volume averaging between the retroprostatic fascia and the mesorectal fascia. We have here the levator length, obturator internus muscle, and we have an important structure here, obturator internus canal, with obturator artery, vein, and nerve. We should focus in this area to check if there is any lymph node enlargement or not. You should check also the internal iliac lymph nodes along the internal iliac vessels, external iliac lymph nodes, and also the presacral lymph nodes, and also the obturator internus lymph nodes. Presacral, obturator internus, external iliac, internal iliac lymph nodes are considered as a lymph node spread of the prostatic cancer. But take care, once we have inguinal lymph node enlargement or common iliac, pre-aortic, retroperitoneal lymph node enlargement, Those lymph node groups are considered as a metastatic lesion, M1, in the staging of prostate cancer. The lymph node enlargement, our criteria, if the short axis of the lymph node more than 8 millimeters, or the long axis more than 1 centimeter or 10 millimeter. Also, if the lymph node is irregular, heterogeneous, restricted in diffusion, all of these criteria that can help you to determine is it metastatic or not. Also, you should know how to differentiate between lymph node enlargement and vascular structure. If you have something like this one, is it lymph node or not? You should check superior and inferior. You will find this structure going from up to down. So it is a tubular structure, so it's vascular structure, vascular channel, not lymph node enlargement. Also, we have here periprostatic venous plexus. And we have also the neurovascular bundle at this area at 5 o'clock and 7 o'clock position. In the coronal plane, you will find the peripheral zone making like heart in shape configuration, as you can see here. And this is the post-seminal vesicles. And this is the transitional zone. T1 with image is very important to detect lymph node spread, neurovascular bundle invasion. As you can see here, this is a new normal neurovascular bundle. It is surrounded by fatty signal intensity at 5 o'clock and 7 o'clock position. Also, any periprostatic fat invasion, it is easily demonstrated in the axial T1 with image. The occipital canal easily demonstrated in the axial T1 with image. The bone marrow and bone marrow deposit can be easily seen in the axial T1 with image. Also, one of the most important spaces in T1 with image is the retropubic space. This space, also called space of Retz's, should be fat signal only without any prostatic invasion. We have some important points in the sagittal vein. This is the uricus attached to the urinary bladder. And we have here, this is the ureter. As you can see here, this is the ureter. And we have this structure is a vas deferens. Find this one. This is a vas deferens. The vas deferens, this is a course of the vas deferens. And this is a course of the ureter. So this is the course of the ureter, and this is the course of the vas deferens. I would like to add something very important regarding the central zone. The central zone has this part. If it is hypertrophied, it can project into the lumen of the urinary bladder as a pedunculated component. And this pedunculated component is called hypertrophy of the median lobe of the central zone. It's called median lobe because it is located between the both ejaculatory ducts, and pedunculated hypertrophy of the median lobe can prolapse to encroach upon the prostatic urethra, inducing urinary obstructive symptoms. By the end of the session, we will finish by the classification of the benign prostatic hyperplasia. We have 4 types. of the benign prostatic hyperplasia. We have the transitional type. As you see here, the transitional zone becomes the predominant enlarged zone, as you see in our case, while the central zone is mildly hypertrophied, and the prostatic urethra is pushed posteriorly. This type is called transitional type or lateral type of the benign prostatic hyperplasia. On the other hand, if we have marked hypertrophy of the central zone and slightly hypertrophied transitional zone, and the prostatic urethra is pushed anteriorly, so this type is called central type of the benign prostatic hyperplasia. Both of these types are called non-balanced or unbalanced benign prostatic hyperplasia. The third type is called balanced prostatic hyperplasia. The hypertrophy of the central zone more or less equal to the hypertrophy of the transitional zone. This is called balanced type of benign prostatic hyperplasia. The last type is the least type, that if we have hypertrophy along the periurethral tissue, this is called periurethral type, and this. So we have four types: transitional or lateral type of benign prostatic hyperplasia, central type of benign prostatic hyperplasia, and both of these types are called non-balanced benign prostatic hyperplasia. The balanced prostatic hyperplasia, the central zone almost equal to the transitional zone hypertrophy, and the least type is periurethral type. I hope you enjoyed our session today, and inshallah, in the next vignette, we will know how to report and what is the standard protocol in reporting of the MRI of the prostate. Thank you so much, and I'm waiting your feedback as well. Thank you so much.